My name is Michelle Chatwin and I'm Head of Research and Education at Briaz Medical. It gives me great pleasure today to introduce Dr. Patrick Murphy, who is a consultant respiratory physician at the Lane Fox unit, which is part of Guy's and St Thomas's NHS Foundation Trust. The Lane Fox unit is one of the largest home mechanical ventilation centres in Europe. Dr. Murphy is probably best known for his role as the lead investigator in the HOT HMV study, which told us about the ideal timing to start non-invasive ventilation in COPD patients. However, today, Dr. Murphy is going to talk about home mechanical ventilation in obesity hyperventilation syndrome, which he has also widely published in. It gives me great pleasure to introduce Dr. Murphy, and I hand over to him for his presentation.
Michelle, thank you for the introduction, and thank you to Briaz for inviting me to talk on what is a vital and important topic for anyone who works in home ventilation. I hope you can see the slides and hear me.
We can see the slides, perfect, and we can hear you.
Excellent. So, as Michelle has already said, my task was today to talk about non-invasive ventilation for obesity hypoventilation. Fine. So the objectives for this talk are really just to define obesity hypoventilation syndrome, and I appreciate most of you will be aware of that. Talk about the types of breathing, the types of sleep disorder breathing in obesity. Talk about the impact both on the individual and on the health system, and then focus on treatment and where we can make a difference for these patients. Now, the definition of obesity hypoventilation syndrome is broad. It is a syndrome and not a specific disease, and therefore it's a constellation of symptoms and signs, and it requires obesity, so a body mass index of over 30. It needs significant sleep disordered breathing. For the majority of patients, that's obstructive sleep apnea, but for a proportion of patients it will be pure nocturnal sleep related hypoventilation, and that's that rise in CO2 levels without upper airways obstruction. Patients need to have daytime respiratory failure, and that's evidenced by a CO2 of over 6.5 kPa or 45 millimeters of mercury if you're using the alternative scale. What's important is it is a diagnosis of exclusion. So it's the absence of another pathology that explains hypoventilation. So the patients cannot have severe airways disease, they cannot have a neuromuscular disease that would also contribute to hypoventilation. There they would have an overlap syndrome rather than obesity hypoventilation syndrome. So really, in those patients where you've excluded other causes of respiratory failure, it's just these three factors: obesity, sleep disordered breathing, and daytime hypoventilation. Now, in terms of sleep disordered breathing, as I said, this is often defined as either sleep apnea or non-sleep apnea, but you can see here three traces from three patients with obesity hypoventilation syndrome, with a simple oximetry, with the red line representing arterial saturation level and the blue line representing pulse rate. And you can see clearly that first trace shows deep, repetitive desaturations occurring persistently throughout the night. On the second trace, those repetitive, rapid desaturations have superimposed deeper, more prolonged desaturations, which are typical of hypoventilation occurring during REM sleep. The final trace, you have those deep and prolonged desaturations, but without coexistent upper airways obstruction or sleep apnea. Now, depending on exactly the definition where you use to consider the presence of significant sleep apnea, this can occur in between 5 and 10% of patients who meet the definition for hypoventilation. So sleep apnea is very common, but is not ubiquitous in this patient population. And I think that's important to understand when we're thinking about treatment modalities. So does this phenotyping matter? Does it matter if you have pure hypoventilation? Does it matter if you have moderate severe COPD, or if you have moderate severe OSA or severe OSA in terms of the phenotype of the patient? And I would say it does matter, because these patients do not have the same cardiovascular risk. And here is very good data from one master in Spain, and shows that when you divide those patients up who meet the definition for obesity hypoventilation roughly into thirds according to ODI, and the first third here represents those patients whose ODI is between 0 and 30. The second ODI, the second tertile here was between 30 and about 60, and then the third tertile was those patients with an ODI of over 60. And you can see that there is a clear difference in the frequency of comorbidities, with actually metabolic comorbidities occurring more in those with milder sleep apnea rather than severe sleep apnea, so the contrary to what may be expected. So those with more hypoventilation having worse cardiovascular risk. There are not the same anthropometrics, so these patients don't have the same fat distribution. There's not the same distribution of gender, and therefore hormones controlling breathing may well have a fact. These patients don't have the risk of the same risk of hospitalization, and they don't have the same response to different PAP modalities. And therefore, I think it's really important that actually, although there is one group that we of a diagnosis in terms of obesity hypoventilation syndrome, we need to be more nuanced than that nowadays, and we do need to look at the different phenotypes, and that allows us to guide our management, not only our respiratory but also our non-respiratory management of these patients. So how common is this, and where should we look for it, and how should we look for it? As I say, it's just those three core features, and I'll come back to that again and again throughout the talk. But those three core features, provide the body with a stress, and that's hypoxia, hypercapnia, both of which lead to sleep fragmentation. That pathophysiology leads to symptoms patients have of hypersomnia, dyspnea, cardiovascular morbidity, and impairment in quality of life, and therefore the burden for patients is significant. If we look at patients with obesity, well, there's a high prevalence of respiratory failure in all patients who present with significant obesity. And if we just look at the general population, and these data, from 3 different countries, Italy, France, in Europe, and the USA, and you can see very similar proportions, higher in the USA than elsewhere. But you can see a clear relationship with increasing BMI leading to an increase in risk of respiratory failure. And you can see once you get to a BMI of over 40, that approximately 1 in 4 of those patients to 1 in 5 will meet the definition for obesity hypoventilation syndrome. So a huge number of people, when we think about the general population and the rise in obesity, just looking at all patients who may have significant obesity, and there is a clinical iceberg of hypoventilation in this patient group. I think these are really interesting data. I mean, they're almost 20 years old, and they're from North America. But what they did is they just looked at all patients presenting to the emergency department, and that was irrespective of diagnosis. And they then just excluded those patients who presented with respiratory problems and looked at those patients presenting with other general medical problems. They categorized them by their BMI here, going in groups of 5, and they screened the patients for neuromuscular disease or airways disease, and in those who had neither, they performed an arterial blood gas. And I think what you can see is quite clearly, as the BMI increases, the proportion of patients with obesity hypoventilation syndrome increases. So these patients were unknown to have significant sleep disorder breathing, presenting for other reasons to the acute general medical take, but you can see a significant number of them met the definition for obesity hypoventilation syndrome. What was also interesting was all of those patients who met the definition had their supervising clinician told, yet less than a third of them left hospital with any form of treatment for sleep disordered breathing. So really tells us that this problem is common and is often underappreciated and undertreated. So sleep disordered breathing is a crucial diagnostic criterion for OHS. So if we just look at patients in sleep clinic, around 10% of them will meet the definition for obesity hypoventilation syndrome, so a significant number. And the likelihood of being hypercapnic increases with increasing severity of sleep apnea. And here you can see once the AHI goes above 60 events per hour, a significant increase in the risk of hypercapnia, and that's mirrored by a significant increase in the risk of obesity as well. So increasing obesity increasing risk of sleep disorder breathing and increasing risk of respiratory failure. So in those patients we see in our simple sleep clinic with OSA, we should be thinking about which ones of them may have sleep apnea and which ones of them we may need to screen. So if we're worried about hypoventilation in those patients who have sleep disorder breathing and obesity, how can we pick that up? Well, obviously the gold standard test would be to do an arterial blood gas, but that's not available to everyone and it can be uncomfortable and unpleasant for the patient as well. There have been a few different systems recommended for screening this patient group, and the use of serum bicarbonate, which is sensitive and reasonably specific for picking up respiratory failure, but also you can use spirometry or daytime peripheral saturations, which have good sensitivity but less specificity than serum bicarbonate, and you need to use whichever of these may be available to you at the time. You can also risk stratify those patients at higher risk, i.e. those who are super obese or BMIs of over 40 or 50, or those patients with the most severe sleep disorder breathing, whether AHIs of over 60 or total sleep time under 90% of over 30%, which does again increase the risk of having daytime respiratory failure. So is this problem common? Yes. And there's a significant increase in the prevalence, not just of home ventilation in general, but of specifically obesity hypoventilation syndrome and how it makes up a proportion of cases. And you can see here data from our own unit where we more than doubled the number of patients we're setting up annually due to hypoventilation related to obesity rather than other disorders. So an nadir there in sort of 2009 of about 100 and increasing to over 200 from 2014 onwards. And those numbers have gradually increased a little bit further in recent years as well. So again, we're left with this triad that we need to be looking for, and it's really important because it is a diagnosis of exclusion, so we need to be thinking about alternatives. We have those simple 3 characteristics we're looking for, but despite it being simple, we know that the prevalence is high and it is increasing with increasing obesity in the general population, that we need to be particularly aware of those patients with severe sleep disorder breathing and sleep apnea, but also actually if we're doing general medicine and general medical take, we need to be aware that this may be presenting with other conditions as well, and really important to pick up and treat at those times. So what's the impact of obesity hyperventilation? Why do we think this is important, and how can we measure that impact on the system? Well, if we're thinking about patients here, you can see somnolence is a huge problem. And here you can see objectively measured daytime sleepiness measured by the Osler test here. You can see significant improvements following non-invasive ventilation, so high level of morbidity with improvement on treatment. Here data again from largely from Juan Fernando Massa, but you can see significant proportion of patients with symptoms, whether that be dyspnea, morning headaches, sleepiness, or peripheral edema, so ranging between 50 and 90% of patients presenting with hypoventilation syndrome have those symptoms. And you can see again really big improvements in those symptoms on treatment. As well as those general symptoms, actually measures of quality of life are hugely impaired in this patient group, and again improve with treatment. So a real burden of disease to the patient and potential for benefit. As well as respiratory disease, one can see that there is a combination of cardiovascular morbidity that can cause problems with this patient group as well. And here we can see patients with obesity hypoventilation syndrome who are also treated for cardiovascular morbidity. We can see here that they have a significant increased risk of death of almost 5 times compared to those patients with obesity hypoventilation who don't have cardiovascular comorbidity. So really important that when we're seeing our patients, again, we're phenotyping them. Are they at risk of cardiovascular comorbidities? What's the sleep apnea severity? How are we treating them? And are we modifying all of those risks rather than just treating one element of the pathology in isolation, because these parts of the disease are all interlinked. Now, as well as the burden for the patient, what's the burden for the health system. And you can see here data looking at patient visits, and we can see that patients with obesity hypoventilation have significantly more hospital attendances than the general population, or as equally matched controls. We can see from data at the bottom right here from Juan Fernando Massa, again in the large Pickwick study, that there was a significant decrease in hospitalizations following treatment with non-invasive ventilation or CPAP therapy, with a similar impact from either of those treatment modalities. So we know the burden on the health system is high if these patients are not treated, and the impact of treatment is huge, improving and reducing mortality and reducing healthcare utilization. So this is an important condition to screen for, to treat, and to reduce that impact. Now, as I showed, those data show that the impact is significantly greater than the general population or obese controls. But I wanted to show the Kaplan-Meier plot above as well, just to show that there is a significant difference between eucapnic sleep apnea and obesity hypoventilation syndrome. And although these conditions are linked, they are not the same. And you can see here much higher rates of cardiovascular morbidity in those patients with hypoventilation rather than those patients with sleep apnea alone. And that translates to an impact on healthcare utilization and yearly medical expenses. So here you can see, whilst OSA significantly increases the cost compared to controls, you can see that in terms of obesity hypoventilation, it's an order of magnitude higher. And so this isn't just bad OSA. There's a huge impact both on the patients, but also on the health system in terms of both financial and also healthcare utilization. So we need to be, screening and getting these individuals, seeing them as separate from sleep apnea, although those two conditions are linked. I wanted to briefly talk about the treatment of patients who present with acute respiratory failure and how they are managed. I'm not going to talk about the acute management of the patient, but what I wanted to talk about was how they're managed at the end of their treatment. So those patients who present with respiratory failure related to obesity requiring acute respiratory support to hospital, we know their mortality is significantly higher than those patients who present in the stable state. Whether that data is looked at by two different studies here, and you can see those patients who've had an intensive care admission with significantly worse survival time than those patients with a similar severity hypoventilation who didn't require an acute admission. So this patient group represents a different phenotype with a worse prognosis, and we need to reflect that in how we manage them. Now, there aren't any randomized controlled trial data of how we manage these patients at the end of that acute admission, but there's a huge amount of observational data, and these data were pulled from the ATS guidance that we wrote a few years ago, and we completed an individual patient meta-analysis using propensity match scoring for those patients who'd had an acute episode of respiratory failure related to obesity, comparing those patients who were discharged on PAP therapy, which was largely 90% here, non-invasive ventilation, a small proportion discharged on CPAP, compared to those patients who were discharged without PAP therapy. And as I said, this was non-randomized, but we tried to match to create as comparative groups as possible between these data sets. And there was over 1,000 patients from 9 different studies. When we pool those data, what you can see is there is a very clear and consistent signal that those patients discharged without PAP therapy had a significantly higher mortality. So at the end of an admission following acute respiratory failure secondary to obesity, there is real evidence that we need to be making sure those patients are discharged on PAP therapy. As I said, the majority of the data from this meta-analysis used non-invasive ventilation. There was insufficient data really to compare CPAP and NIV in this patient group, but there was no evidence that there was a difference in the small amount of data where we did look. However, I think what is clear is not only should they be discharged on PAP therapy, but given the high risk, they need to be referred on to a specialist service for ongoing management. So how about obesity hypoventilation syndrome in the stable ambulatory patient? How should we manage this group? we need again to think about what's the target of our therapy, and we want to target that underlying pathophysiology. So we can target both sleep disordered breathing and respiratory failure with non-invasive ventilation. And the aim of that treatment is to improve those patient relevant outcomes: hypersomnia, dyspnea, cardiovascular morbidity, and quality of life. And there's good evidence that NIV helps that. And some of these data I've showed already, but we can see there's a reduction in sleepiness, reduction in dyspnea, improvement in quality of life, a reduction in hospital admissions, and a reduction in mortality, both in the short and the longer term. So really significant changes. Here you can see from a physiological perspective, you can see that there are significant improvements in terms of respiratory failure, and those improvements are very similar whether it's with non-invasive ventilation or CPAP therapy over a prolonged period of time. So really good evidence that those two treatments in stable patients do have similar outcomes. And how about the clinical response? Well, not only does the physiology improve, but in terms of cardiovascular risk, in terms of mortality, in terms of healthcare utilization, you can see that actually there is very similar outcomes with a significant reduction generated by both CPAP therapy or non-invasive ventilation. So really powerful data that these patients benefit from treatment, and the exact modality needs to be distinguished. I think it's really important to realise that from my perspective, I don't think the right question is to ask, should we be using CPAP or an IV? The question should be, how can we control respiratory failure? And here you can see with these data that the proportion of treatment failure where the patients were initiated on CPAP or an IV is very similar, and the improvement in respiratory failure is similar. And the reason for that is because the titration policies were similar, whether you had CPAP or an IV. So a similar control of sleep disordered breathing, and we can see that in the study from Piper up there, where in table 3 from 2008. Very similar control of sleep disorder breathing, whether CPAP or NIV was used, and that leads to very similar outcomes. And that's really important. How you control the sleep disorder breathing is less important. The important thing is that it is controlled. And these are good data to show the importance of that. And they looked at those patients who had a single night on CPAP with obesity hypoventilation syndrome with significant OSA. So not those patients with pure hypoventilation without upper airways obstruction, but those patients with both OSA and respiratory failure. They showed that there was improvement over time. However, there were a proportion of patients who were still uncontrolled at 3 months. And the best way of predicting those patients who were uncontrolled at 3 months was to see those patients who were uncontrolled at initiation on that first night of therapy. And that, I think, is understandable. Where we look at the criteria here, we can see there are some sensible cutoffs we can apply. So you're much more likely to fail CPAP therapy if on that first night titration, your mean CPAP, your mean oxygen saturation, on CPAP were less than 90 overnight. If your early morning CO2 was over 7, or your pre-treatment CO2 was over 7, you're much more likely to fail CPAP therapy. And similarly, if on CPAP therapy, the proportion of your sleep time under 90% is over 10%, you're again much more likely to still be uncontrolled at 3 months. And I think those are really useful cutoffs for us to say, well, we can try CPAP, but if we don't achieve success and control of the sleep disordered breathing, we know that sleep disordered breathing is what's driving the respiratory failure, and therefore failure to improve that will mean that treatment failure is much more likely. So for those patients that we establish on NIV, maybe we should be switching those back to CPAP therapy if we've controlled the CO2 level. And there's a few studies looking at this. This is one from a few years ago. I think what's important to see is that they excluded a significant number of patients initially before the baseline sleep study, but even after completing a baseline sleep study on an auto-titrating CPAP device, they found that those patients who were well controlled on NIV with stable eucapnia had poor control on APAP therapy. So about 1 in 3 to 1 in 4. Those patients who had an acceptable response were therefore then sent home for a relatively short trial, 4 to 6 weeks, and then had a further polysomnography at the end of that treatment period. And you can see the majority of patients had successful treatment at the end of that period, but still a proportion of patients who had failure of CPAP despite being adequately controlled within the early stages of the process, reflecting that there is probably some hangover effect in terms of the NIV improving central drive that may well therefore be lost in a proportion of patients when we push them onto CPAP therapy alone. These are data that we collected along with Maxime Bertou in Rouen in France, and they looked at their cohort, again looking at those patients with stable OHS who were already on NIV, who were adequately compliant and had a good response to treatment defined by eucapnia and resolution of symptoms. And a small number of those, 19, were stepped down from NIV to CPAP therapy. But you can see actually a significant number, over a third of those patients failed that step down process. 5 with recurrent hypercapnia, 2 died within 6 months of therapy despite being stable prior to this, and 1 patient preferred to switch back to NIV due to a worsening of their symptom burden. So I think what's clear is that we know that positive airway pressure therapy, whether CPAP or NIV, improves outcomes in patients. However, what's also clear is that CPAP is not the best treatment for all patients. And we should be really aware of those patients with more severe sleep disorder breathing, those patients who've had acute respiratory failure, and those patients who have a poor initial response to CPAP therapy should be considered for more advanced ventilatory strategies. So what do we do at the Lane Fox unit? And our conventional practice is, going back to those 3 phenotypes, a sort of very OSA predominant patient whose CPAP, may have a good response to CPAP therapy, where the level of obesity is moderate rather than severe, where the respiratory failure again is moderate with a CO2 of less than 7. We consider those patients for initial treatment with CPAP. Those patients with more obvious hypoventilation, those patients with more severe hypercapnia and more severe obesity, we would often treat first line with non-invasive ventilation, and we would consider CPAP step down later on in the treatment choice, but depending on symptom burden and the resolution. And in those patients who we do step down, we always perform ongoing surveillance to ensure that their respiratory failure and symptom burden remains controlled. In those patients with what I would call pure hypoventilation, so those without significant OSA, and again the cutoff can vary, and whether you choose an ADI of 5, 15 or 30, it does vary the proportion of these patients, and that does vary in the literature. Broadly, we use a cutoff of 15, and even then, if the hypercapnia is mild, and even if the obesity is mild, if that severity of the sleep apnea is also only moderate or mild, we would use non-invasive ventilation as our first line therapy. So how about more advanced modes of non-invasive ventilation? If we know that CPAP may help, and we know that non-invasive ventilation is broadly similar in a whole population, but on an individual patient basis may make a difference, is there a role for auto-titrating NIV that may better match those variations that happen during sleep stage and sleep position? And there was early data, and this is data that we published a number of years ago now, showing that if you used a similar titration policy, that you could achieve similar results with both standard fixed bi-level pressure control and an average or a volume assured or a volume targeted pressure support. And you can see that the delivered pressures from the ventilators were very similar in this patient group, similar control of sleep disorder breathing, similar outcomes in terms of patient reported outcomes in the longer term. And how about further advanced modes, not just using target volume, but also auto EPAP to control? And there's several studies now demonstrating good control of upper airways obstruction, good control of sleep disorder breathing, and some evidence to suggest some soft benefits of patients in terms of improved compliance and improved subjective sleep quality, which means you may wish to consider these target volume auto EPAP modes in those patients whose compliance is less good or who subjectively still have some ongoing sleep disruption on fixed bi-level ventilation. There's also the potential to use auto-titrating modes to facilitate outpatient setup, and this data we published towards the end of last year, looking at a novel setup pathway using an auto-titrating device in the outpatient with an auto EPAP target volume mode rather than an inpatient admission. and we randomized those patients with stable hypercapnic respiratory failure, looking both at cost effectiveness but also a safety endpoint of CO2 control. We showed that there was very similar control in terms of respiratory failure between the outpatient and the inpatient mode, suggesting that this is a safe strategy. In terms of cost effectiveness, there was very similar costs between both strategies, and therefore along with a similar improvement in quality of life, meaning that the quality of life adjusted months or adjusted years, if one was to roll it out further, was very similar. So similar physiological effectiveness, similar cost effectiveness, similar clinical effectiveness. And so if one's thinking about this in practice, all roads lead to Rome. And again, the story is the same. In particular relevance for the post-COVID era is that we can flex between our approaches, is that we don't need to just use a simple approach of all patients come in for an inpatient study, which may be easier or harder during certain times during the pandemic. But actually saying, well, if we use an auto-titrating NIV device, we can do that as an outpatient with good effects. And we can therefore tailor, depending on how our service has space and capacity, to make the patient have treatment and have control of their respiratory failure at the right time. Now, I think it is really important to remember that obesity hypoventilation syndrome has these three features. So we've talked about sleep disordered breathing and we've talked about respiratory failure, and those are both effectively targeted with non-invasive ventilation. However, obesity, is often the neglected element of that triad, and it's really important to understand and acknowledge the impact that has on severity of symptoms and the burden for the patient. And if we don't address that as respiratory clinicians and allow that to be someone else's problem, then unfortunately our patients will continue to have significant morbidity. Now, we know that non-invasive ventilation, although it's targeting sleep disordered breathing and respiratory failure predominantly, we know that actually there's very good data suggesting that it's associated with improvement in physical activity, and that physical activity relates to a reduction in patient weight, which can be shown by bioelectrical impedance to be fat mass rather than just resolution of pedal edema. And I think this is important because it means that we can try and optimize those patients when they come and see us and we're initiating non-invasive ventilation. We followed on from that initial data, as I said, to say, well, let's see if we can enhance that effect. We start non-invasive ventilation. We know the patient may have more energy and do more, but can we get them on a rehabilitation program to further improve that? And the evidence was promising that with a bespoke protocol with motivational interviewing and rehabilitation and nutrition from a multidisciplinary team, we could triple that weight loss there. You can see an average of 3 kilograms weight loss in those patients who receive standard care, compared to nearly 10 kilograms in those patients receiving the intervention in that bespoke nutrition and rehabilitation program at the time of initiation of non-invasive ventilation. So again, a really important time to say, when I'm starting this treatment for their respiratory failure, I also need to be addressing their obesity. I think what we do need to acknowledge is that those weight losses, whilst important, are small compared to the weight loss that can be achieved through bariatric surgery, and the level of weight loss that's going to improve respiratory failure and sleep disordered breathing, it is, broadly speaking, 10%, and therefore probably we need to do more than we can achieve just with rehabilitation and conservative intervention. But we need to think about when these patients are appropriate to refer on for bariatric surgery, and that surgery can be performed safely when those patients have control of their respiratory failure with non-invasive ventilation, and the outcomes can be excellent. And so what we need to remember is, when we're initiating these patients, we should be having discussions with them about suitability for bariatric surgery. We should be referring them on for specialist weight loss, and we should be using it as a real important time to interact with these patients and maximize the chance of them having successful weight loss, because that will reverse a huge number of the other comorbidities associated with this condition. So really, just to summarize, we've talked about an awful lot in in the management of obesity hypoventilation syndrome. But I think when I think about the timeline for the patient, I think this is really important. At day one, when we see the patient, we should be phenotyping them. We should be saying, what type of sleep disorder breathing have they got? What does that mean for their comorbidities and their risks? We then need to be making sure that we intervene, that we control their sleep disorder breathing. So we don't just give them a machine and send them on their way, but that we make sure that whichever machine we give them, whether it be a simple CPAP machine, whether it be fixed bi-level or an auto-titrating device, we need to make sure that those settings are titrated to control their sleep disorder breathing and reverse their respiratory failure. And we can say to the patient, because we know they need buy-in for treatment, because CPAP and NIV are difficult treatments for some patients to manage. But we can say, well, within the first few days, you should start to feel less sleepy. Within a month, we should be seeing them again to check their respiratory failure has improved. We should be monitoring their weight at their follow-up at 3 months, because we know that's the time that we can expect that to start to get better. And if it's not, we need to be looking at other interventions. And as we follow them up in the longer term, we need to make sure that we're optimizing their cardiovascular morbidity. We need to be looking and telling them about the benefits in terms of reduction in mortality and reduction in terms of their contacts with healthcare over that longer term, because those are important messages to the patient to understand why they need this therapy that can be difficult to manage. So in summary, what would I like you all to take from this talk? And I hope I've been clear that obesity hypoventilation syndrome is common, and not only common as it's frequently missed. Even when clinicians are informed about it, as they were in the NOBLE study, they often don't go on to treat those patients. So we need to bang the drum with our general medical colleagues and non-specialists to say these patients need to be referred on. Obesity impacts on almost any services, but we particularly need to link in with simple sleep services, with bariatric services, with endocrine services who are seeing patients with obesity and comorbidities, and get them to refer on those patients with the potential of respiratory failure. Hopefully I've made it clear that OHS is not just bad OSA, that it's an order of magnitude worse and therefore needs to be treated and managed in a different way. The treatment for OHS may be CPAP for some patients, maybe non-invasive ventilation at fixed or auto-titrating modes, but that needs to be titrated and managed by an expert team to make sure that is appropriate for that individual patient. Those auto-titrating modes can be used as a cost-effective way of implementing an outpatient pathway, but we should also be remembering that we're not just managing that patient's respiratory failure, but we need to intervene in their weight management as a whole and be promoting weight loss interventions throughout their disease progression. And I think I hopefully made it clear that one of the reasons to do this is because, successful treatment makes a huge difference to patients and does improve, clinical outcomes for the individual patient, but also for the health system as a whole. Thank you very much for your time. There should be, I think, 15 to 20 minutes for questions. I'm happy for you to also contact me directly if you wanted to ask any further questions that we're not able to answer today. And I think the final slide here was just as a reminder for the next talk, who will be given by one of my colleagues from the Royal Brompton on paediatric home ventilation.
Thank you, Dr. Murphy, for an excellent presentation. That's really given us some food for thought. So first of all, I would just like to read someone who wants to also thank you for an excellent lecture, Dr. Svendmyr from Gothenburg in Sweden. He makes a comment. He says, I agree that OHS is often underdiagnosed and needs to be considered before sending an obese patient that has required ICU care home. Without NIV, it's likely that these OHS patients will be back in the ICU within days or a few weeks, and that the time window for these patients is much shorter than the typical OSA patient. Perhaps you'd like to comment on your experience, because I know that you cross-cover the ICUs as well.
Yeah, I agree completely. I think, that it is clear that if the patients, I didn't present all of the acute data, but about if you look at those patients presenting with acute respiratory failure with obesity, about a third of them have decompensated heart failure that's contributing, about a third of them have a respiratory or other infection that's causing them to decompensate, and about a third of those decompensations are idiopathic. So in 1/3 of patients, it is just purely the sleep disorder breathing we think that's driven them into decompensated respiratory failure. And in the other two groups, you've got another treatment, another condition to treat. But there's good evidence, as you say, that if you don't continue long-term treatment with PAP therapy, that the relapse rates are significantly higher. And so our clinical pathway is to screen all of those patients who have respiratory failure, who present with respiratory failure where we think obesity is contributing. Once they're stable and the acute heart failure or respiratory infection and the decompensated element of the respiratory failure is controlled, we give them clinical screening, and we know that the severity of sleep disorder breathing during that acute admission is unreliable. So we generally don't screen them for sleep apnea or other breathing problems at that point. We will often treat them empirically with the ventilator settings that have controlled their respiratory failure, discharging them with non-invasive ventilation, and then readmitting them for a sleep study off therapy between 6 and 12 weeks after hospital discharge to maintain the patient's safety, but also to make sure that they're having a proper evaluation at that point to see whether actually non-invasive ventilation does need to be considered in the longer term, or whether their decompensation was purely related to the acute episode.
Paddy, you mentioned settings, and settings is a particular theme that's come through on the Q&A. You talked about using targeted volume modes as if people are using it in the outpatient setting, but do you think that these are also appropriate for those who you're just not quite sure what the settings are going to be? And then if you do prefer fixed level settings, what sort of IPAPs and EPAPs are typical for this group of patients is the second theme that's come through.
So I think they're really good questions, and we have predominantly used an inpatient titration model where the patient will be in hospital overnight with the bedside nurse adjusting the pressures dependent on the control of their sleep disorder breathing on their respiratory sleep study. So a dynamic process, and usually then their patients are in hospital for 1 or 2 nights to get that level right. We have a titration protocol that starts for those patients who have obesity hypoventilation with significant OSA. So we usually start at an IPAP of 18 and an EPAP of 6 with a backup rate of 14 and a TI of 1.4 in a standard fixed mode. The average discharge settings are an IPAP of 24 and an EPAP of 8 with the same backup rate and TI. So a bit of up titration that occurs during that night. There is obviously a range within that, but they're the mean settings that we get to on our nights. We use a fixed level as our first line. That's from our perspective, we are most familiar with that. For the majority of patients, it works well. For those patients where we can't get good control, for those patients where we're finding they're needing high pressures during part of the night, so they have, much more profound postural related symptoms and therefore are needing high pressures, but only in certain sleep positions or sleep stages, we then think about adding in a volume targeted mode to try and offset some of that, so we're not ventilating at very high pressures for the entire duration of the night, because that can be difficult to tolerate. And similarly, again, those patients with significant pressure related side effects, we often will think about using a target volume mode in those patients so that they get variability over the night, and therefore they're not constantly getting the high pressure that may contribute to aerophagia and some of those more unpleasant symptoms that can limit non-invasive ventilation use in the home setting.
And just, I'd really value your comments on just auto EPAP, so not using necessarily the auto EPAP with a targeted volume mode, because clinically I was finding that this could be quite effective, possibly more so than a fixed level of EPAP in this patient group. And that surprised me because, as you know, sort of historically I've come from a very fixed level pressure titration manually rather than using something that automatically does it.
I think equally we were skeptical of this as a technology, and it has its limitations. I think what's really important is to understand how the algorithms work, because it's not right for every patient. Some of the algorithms use a flow-based analysis, and therefore, particularly in patients with very high pressures or very high leaks, it's less likely to be accurate. Some more of the modes are using forced oscillatory technology. That's much more flow independent, and therefore should be more stable even at higher pressures. We know that there is significant variation night to night and within night in the pressure required to maintain airway patency, and that setting a fixed level at the 95th centile achieves good control, but it also comes at a consequence of an overall elevated pressure for parts of the night when you don't need it. And that overall elevated pressure definitely contributes to patient intolerance and side effects. The data from all of the studies across all of the different manufacturers, so all of the different algorithms, the data are very consistent that these modes can control upper airways obstruction well, that they are often associated with a slight reduction in total pressure delivery that can improve symptoms, that there is a subjective improvement in sleep quality from the patients, and that subjective sleep quality is usually associated with an increase in compliance. Now, there's not evidence that these modes improve long-term clinical outcomes. Now, all of the studies that have been performed have probably been underpowered to detect the sort of size differences we're talking about with these problems, and therefore we've seen this as a useful mode that one can use, but isn't required all the time. Because for many patients, as I say, CPAP will suffice for some, fixed bilevel will suffice for some, but some will require auto EPAP and or target volume modes. And I think it is just being dynamic in your strategy, looking at the patient and saying, well, as I say, do we have control of their sleep disorder breathing? Do they have symptoms that are pressure related that may benefit from the variability that auto EPAP offers? And as you say, having a simple fixed pressure above that is often a simple way of doing it. I have to say our strategy has been to use the auto EPAP always in a target volume mode, and that's just habit rather than that necessarily is better. But we do use a relatively narrow window for the pressure support, so we don't just give the algorithm the chance to run from a pressure support of nothing to the maximum IPAP. We usually give have a range of sort of 4 centimeters of water above and below what we think the optimum EPAP is, so that there is some pressure change, but not huge changes that might disturb the patient's sleep quality.
Thank you very much for that. I'm going to take you back, I'm afraid, towards the start of your lecture, and I have a question about, or I personally don't, the audience does, about carbon dioxide monitoring, in that they don't have that available to them. So is venous blood gases, arterial blood gases, a worthy tool in this patient group?
I think it's a really good question, and we are lucky that we've had good access to transcutaneous CO2 monitoring, and that's been one of the key aspects that we've used to titrate ventilation. I think, unfortunately, venous blood gases, that there is just such variability in terms of what that CO2 level is. Also, the time it's been taken from wakefulness, also the sleep stage the patient has been through, means that it can be really difficult to use. An early morning ABG is better than a venous blood gas, it's more reliable, but even then, again, we often see changes of 1-2 kilopascals between the last phase of REM and the end of sleep, and that generally improves a little bit further on wakefulness. So you're getting a single snapshot that doesn't reflect the dynamic process of sleep. You can only use what you've got available. What I would say is that the transcutaneous CO2 devices are becoming increasingly available. They are, although they are costly, they are not as costly as they once were, and they are much more reliable in terms of patient use, and the study failure rate is low. And my advice would be, to get good control, one really needs to measure the CO2, because that's what you're trying to target.
And just with the CO2 monitoring, these patients can be a little bit tricky with the probe and getting good signals, shall we say. Do you have any tips about that, and where is your favourite place to try first?
So we generally use the forehead first. That's because, again, from a cost perspective, the sensor holders are cheaper than the earlobe holders. However, the signal is definitely better on the ear. So for those patients where we don't get a good signal, where we're expecting not to get a good signal, the earlobe is much better. That's my clinical practice, and actually there are some published data to confirm that the reliability of the signal is much better at the ear than it is at either the forehead, or the shoulder, or the sternum, which is the other sites that are often used. I think the other thing I'd say just is also that skin prep is really important. So the patient needs to, the skin needs to be clean, cleaned with soap and water prior to the application, and then further cleaned again with an alco wipe as well, to make sure that that the skin itself isn't being a barrier to good contact and good signal acquisition.
And you at the start showed oximetry defining the 3 phenotypes that you see. Is it, obviously oximetry is a really readily available tool and can give you good information. Is it enough just to use oximetry, or would you prefer to have polygraphy and then potentially bring them back if they needed to for CO2 monitoring, if that was harder for you to provide?
I think they're good questions, and one, as I say, needs to work with the tools you've got available, and I think also what's cost and clinically effective, and in the same way that there are tiers of the support you can give to the patient, there are tiers of the monitoring that are needed as well, and for those patients with more straightforward obesity hyperventilation syndrome, so where the respiratory failure is less severe, the daytime CO2 is less than 7, they have severe OSA, they haven't had an acute ICU admission, then I think it would be a very reasonable approach to use overnight oximetry, because they're not getting supplementary oxygen, and that, tied with regular arterial blood gas monitoring during follow-up, would give a very good way of controlling those patients. Those patients where you struggle to get control of either the daytime respiratory failure or the overnight sleep study on oximetry, those patients who require oxygen therapy, those patients who have more severe respiratory failure where the CO2s are 7 or much higher, those are the patients where I'd focus if your resources are limited, those more in-depth sleep studies. As I said, I think transcutaneous CO2 is the most helpful. Polygraphy has a role when looking for significant asynchronies, but in our experience, actually, that's generally best used further down the line once the patient has been established, because I think our experience around this is that lots of the asynchrony starts to improve over that first 3-month period, and if you try and control all the asynchrony at the outset, actually that can be very time consuming when most of those patients won't impact on, and so we save polygraphy for those patients where we've set them up, we've established respiratory failure, but unfortunately we're not able to get adequate control with those, using those standard strategies.
The last 3 questions, you've sort of answered one of them. One was about do you look for patient ventilatory asynchrony and how important it is? And then leading on, because it's almost part of it, was looking at the built-in downloadable data from the ventilator software. How much do you use the AHI? And then the third question, because they all tie together, is do you use telemonitoring in this patient group?
So I think all really good questions. new technology is always something that I think we're interested in evaluating and gaining experience with. There's been a huge interest in telemonitoring and in polygraphy. I think it's something that definitely we need to know more about. So I think I can't give a definitive answer on what to do, but what I can say is what our practice is. As I said, we've also alluded to, is that we often don't actively look for asynchrony early in the initiation process, because our experience in the studies that we've done showed that actually it didn't help, and most of it resolved over the first 3 months period. And we couldn't show that aggressively managing it in all of the patients improve things, but we do certainly use it in those patients who are struggling, particularly in those patients who report hunger overnight, who report arousals and asynchrony overnight in terms of awakening with dyspnea. So those are the patients we try and focus on, and those patients with COPD who have deventilation dyspnea, another patient group that often we find asynchrony can be prevalent and targeting it can be clinically useful. In terms of the downloads, we're increasingly using this, and we used it a lot more during the pandemic when remote consultations were in place, and it was incredibly useful. I always see data from remote and from telemonitoring in context of that patient. So I never look at the data without looking at the patient. And so if the AHI is elevated, but their respiratory failure is controlled, their symptom burden is controlled, they've got good usage of the ventilator, then I don't try and make the number better if all the clinical factors are already good. However, if that patient has symptoms, it does provide a useful way of saying, well, actually, maybe there's some sign that we haven't got the sleep disorder breathing controlled, and then we can bring them in for a more in-depth analysis. So it allows us to better focus, because I think where the number, where the AHI is normal, one might look at other strategies first, or managing some of those symptoms. Whereas if it's abnormal, it gives you a clearer steer that their sleep disorder breathing is not controlled, and manipulating the ventilator may be the answer. Does that answer all three? I think it does.
It does. Can I just ask a comment based on, you sort of said don't get too hung up on numbers. Yeah. In a way, and I'm sort of going to generalize this, because some patients with obesity hypoventilation syndrome, you can't normalize their gases, and it's whether you would also have a adoption in this situation. If they're symptomatically better, they're feeling better, and you've got them as good as you can, you sort of accept a permissive hypercapnia, or would you always try and continue further to normalize the CO2 in this group, which is different to the COPD population?
Yeah, no, I think it is different, and it's a really important question. I don't get hung up on the numbers, but maybe CO2 is one of the numbers I do get hung up on. I think, and that's because we know that persistent respiratory failure, is associated with poor outcomes. Depends on the severity. CO2 of over 7, I always try and treat. If it's between 6.5 and 7, it does depend on the patient and the pressures they're on, and whether I think we can optimize that anymore, or whether I think further pressure improvement or further optimization might actually worsen their comfort and therefore impact. So whether it's modifiable. If it's less than 6.5, then often, unless their symptoms are very severe, then I would allow that to manage, and in a proportion of patients.
I know you've got to go to clinic, so I want to thank you for your time. I think I could probably chat to you for at least another 2 or 3 hours, because there are more questions buzzing around, but we're going to have to leave it there. So thank you for attending the webinar.